Thank you so much, and thank you. It's been a great weekend here in Las Vegas. This is a topic that I'm just so excited about and I think is so important. I was sitting just a few months ago giving a deposition saying that I didn't think it was such a good management scheme to do a lumbar facet injection that took about 5 minutes and resulted in a patient's death from propofol. And as I was discussing it, I dwelled on the fact that this was not the first case that I was sent. In fact, it probably was closer to somewhere around the 40th or 50th case. And in my thought, I called up Dr. Manchakanti and said, Dr. Manchakanti, I have an idea. Why don't we work on some guidelines for sedation and see where it takes us, get some of our experts and create these so that we can reduce morbidity and mortality in our patients that we are doing procedures on. The other part of the litigation that I've seen that have been sent to me dozens and dozens of times involve injections basically under deep or sedation or general anesthesia, and the needle was placed, if you can imagine a cervical epidural, the needle was placed in the spinal nerves, and that's not what did the damage. The damage was the injection. And because the patient was unconscious, they were not able to react and cue the pain physician that maybe possibly, very likely, that the needle was in the wrong place and remove it and replace it. And so those are the two areas that are really behind this, and hope everyone in here can think about and consider in your practices. These guidelines will be coming out in a matter of months. And though I don't have them all spelled out here, what I've described with a few examples are the impetus for why I've spearheaded them. And I want to thank Mark Jones, who's now on a plane going back to Boston, for his help in both making the guidelines and this slideshow as he made the first draft of it. So we do tens of thousands of interventional pain procedures, and of course there's variation in how we go about doing things. As I said, the two big things are aberrant needle placement and hypoventilation, respiratory depression, and subsequent anoxic brain injury. How many of you know somebody, maybe a colleague or yourself, who have had one of these catastrophic outcomes? Okay, so and my point is, wouldn't it be good if nobody raised their hand? Wouldn't that be good for every reason we can think for what we're doing every day? And so hopefully you'll take me serious and get a jump on this. So we've published 2 books on sedation. So the topic of the book was sedation. And we've done this because the majority of anesthetics are given by non-anesthesia providers. And the point being that in general, and I'm not talking about the most complicated procedure involving, tunneling through half of the body. I'm talking about an SI joint, a facet, an epidural. Mild to moderate sedation is generally appropriate. Deeper sedation in general anesthesia is not. Okay, and I know that everyone's saying, well, what about there's an exception? I know that. But I'm saying in general, the majority of what we do can be done with mild to moderate sedation. And if you don't know the difference between mild and moderate sedation versus deep sedation in general anesthesia, you can buy my book, or you could talk to me, or you could Google it. But we have a lot of people in anesthesia who go into interventional pain, but not everyone here and in our ACIP organization has an anesthesia background. And as I said, therefore, the person providing sedation should not as well be the person doing the procedure, and that person should have training and skill we had in a neighboring state a sedation nurse who gave 19 milligrams of midazolam and 200 mics of fentanyl to a 34-year-old for, again, a lumbar facet 5-minute procedure. And amazingly, she ended up with anoxic brain damage and is a vegetable. So I've made the point, and I can give you 50 more examples of permanent neurologic injury, hypoxic brain injury, and death. And so the drugs that we use for either deep sedation or general anesthesia, so let me be specific, propofol, oh wait, did I say propofol? Yeah, propofol, etomidate, and ketamine would not be the drugs that you would want to use. The reason for propofol is that it is very tricky in that you can go from mild to moderate sedation to deep and then general anesthesia within seconds. And remember, this is in the context of the majority of our patients being prone. The next thing is monitoring. You know, if I had a nickel for each of these cases where there was anoxic brain damage and there was not an end-tidal CO2 monitor, I would have at least $10. So please, in your practice, if you don't have continuous end-tidal CO2, get it immediately, because you will minimize morbidity and mortality regardless. Our patients, and I have a slide coming up, take medications before they get there. They're on chronic opiates. Some of them are on muscle relaxants. Some of them are on benzos. And many of them will pre-medicate because of the dynamics of anxiety and chronic pain, the dynamics of hyperalgesia from long-term opiate use, and so on and so forth. And so that's what this slide talks about, that we have to manage patients who have a number of different coexisting problems, typically anxiety, perhaps opioid hyperalgesia, and that these drug interactions can lead to morbidity and mortality in that typical dosing that we might give for someone who is on these medications and pre-medicated and taken triple the dose may be different than a normal population. So drug selection, we went through this. Midazolam is very acceptable. I typically give somewhere between 2 and at the high end 4 milligrams of midazolam. In our guidelines that we are processing, we know there's a range, and we know there's a range of patients. We know all that. But as far as propofol, as I've said 4 times, which is the cliff notes of this, really you're going to get into trouble, and you're going to end up with respiratory depression. You're going to end up with anoxic brain damage, and or you're going to end up with a needle that's aberrantly placed for which the patient cannot communicate and give you a clue that you might want to pull it out. Now, I was talking to one of my colleagues here who I know really likes to use propofol, and I've been trying to get him to come to my camp, and he said, well, you know, we use dye, so I would know that I was in the wrong place. And I really felt like at least he was considering my thoughts. I did spend a half an hour with him going through and telling him about all of the morbidity, mortality, the cases that I've seen around the United States. And so to the heart of it, we really need to not give propofol for the majority of these cases. Midazolam, and if we need to, a small amount of fentanyl would probably be the right recipe that we're looking for. With regard to NPO status, there's a lot of work done through the American Society of Anesthesia, and there's a lot of interesting data in that, as you see here, most patients who have pain procedures do not have consequential aspiration. But I was just out talking to some colleagues just a half an hour ago, and they were telling me about a patient who ended up with aspiration and is a DNR at present. So these guidelines are there through a lot of work through the American Society of Anesthesia. We have added these into our guidelines, which would be prohibiting clear liquids for 2 hours and light meals probably for 4 hours. Some people say 6, but probably 4 hours would be fine. And that actually NPO for 8 hours, there are worse guidelines because there are consequences to be NPO longer than that. Okay, and high-risk people, certainly we all know how to manage and to take care of accordingly. So to conclude, we have ACIP guidelines that will be coming out later this year. They're very overdue. As I've said, since everybody raised their hands that they or someone they know has had one of these catastrophic outcomes, we really need to step up for patient safety. And I'm really excited that Dr. Manchikani has helped me spearhead this to bring a lot of our leaders to provide input and hopefully to do some good in the future. And I know we talked about guidelines and should and must, and I'll let all those people sort it out. But for me, this is all of substance. That propofol should not be used in the majority of our interventional cases, but rather mild or moderate sedation, that being midazolam, and if needed, a small amount of fentanyl.